Welcome everyone to CF Canada's Access to Medicine WebEx. This WebEx is part of a two-part series about CF Canada's campaign related to a new CF drug called ORKAMBI. An earlier segment outlined some of the advocacy work that CF Canada is doing, as well as some of the work that you can do to help ensure that people with CF can gain access to this new drug. But what is this new drug? Lumacaftor ivacaftor, also known as ORKAMBI, is what we're talking about today. And the purpose of this segment is to give you a bit of information about what this new drug is and how it works. Joining me is John Wallenberg, CF Canada's Chief Scientific Officer, to help us understand this new CF drug and what it might mean for patients with CF in Canada. Over to you, John.
Thank you, Sarah. So, as everyone hopefully is aware, cystic fibrosis is a genetic condition. It's caused by mutations in a gene called CFTR, which stands for Cystic Fibrosis Transmembrane Conductance Regulator. I like to liken it to windows in the wall of a house. I'd like you to think of cells as being the house, and every cell in the body needs to be able to communicate with its environment. Needs to have some means of allowing nutrients to come in and waste to go out. And in this particular case, what it needs to be able to control is the transport of chloride ions from the cell outside. It also transports bicarbonate. So cystic fibrosis, CFTR, the gene product of CFTR is like a window in the wall of the cell, and it allows for the transport of chloride and bicarbonate out of the cell. In cystic fibrosis, that window is defective, and there are a number of different ways that that defect can be described. In some cases, the window is installed in the wall of the house, but it's sticky and it doesn't open very well. That's the case for the G551D mutation that is treated by a drug called Kalydeco or ivacaftor, as Sarah mentioned previously. Ivacaftor comes in and it acts as a lubricant, and it allows the window to open more easily. In the case of the most common mutation, the delta F508 mutation, the mutation causes a different defect. The protein that is coded for by the delta F508 mutation creates what I will call is a deformed protein. Think of it as a twisted window frame. And that window frame never gets installed at in the wall of the house. There's a guy standing at the bottom of the stairs of the basement where the window frames are made in the house, and he looks at these twisted window frames and says, that's never going to go in the wall, and he sends it back somewhere else for recycling. So, one of the drugs in ORKAMBI, Lumacaftor, helps to straighten out the window frame and allows that protein to go up the stairs and get installed in the wall of the house. The challenge is that even when the delta F508 window frame is installed, it's still sticky. That's why ORKAMBI is a combination drug that includes both Lumacaftor, which helps straighten out the window frame, and ivacaftor, which helps lubricate it. So now, using ORKAMBI, you get both production of functional protein, which gets installed in the wall, in the surface of the cell, as well as improved opening of the channel to allow the chloride ions to pass in and out of, or to pass out of the cell and into the environment. The reason this is important is because that the transport of chloride ions out of the cell also impacts on the transport of water out of the cell. And this is what controls the water in the mucus, especially in the lungs. So when there is very little chloride ion being transported out of the cell, the mucus in the lungs is thick, it's sticky, it doesn't flow well, it traps bacteria and serves as a surface for chronic infections that lead to cycles of inflammation and deterioration of lung capacity. So ORKAMBI, again, is a combination of two drugs, one that allows the delta F508 protein to be transported to the cell wall and installed, and I have a catheter that helps ensure that the protein that is installed can open and allow for the transport of chloride ions. What's important about that is that it means that ORKAMBI is only good for patients who have 2 copies of the delta F508 mutation. It's not sufficiently efficient as a corrector to be able to help patients who have only 1 copy of delta F508. So, ORKAMBI was tested in clinical trials called double-blind. That means neither the patient nor the doctor who treated them knew which patients were on drugs or which patients were on placebo. 1,108 people were involved in the trial, and 2 groups of patients were on drug, one on 1 dose, which was 600 milligrams once daily, and 1 group on 400 milligrams given twice daily. About 371 people were in a placebo group. What the clinical trial showed was that people who were on ORKAMBI had improved lung function. It was less of an impact than patients who are on Kalydeco, so it was a relatively modest improvement in lung function. FEV1s went up on average about 3%. However, very importantly, ORKAMBI reduced the number of exacerbations, also called the lung infection flare-ups, that people who were on the drug suffered. And those exacerbations were reduced by about 50%. This led to fewer hospitalizations and improved long-term, with expected improved long-term outcomes. Or patients on ORKAMBI also noted an increase in body mass index, or improved weight, basically. All told, all of these things lead to better outcomes in the long term for patients with cystic fibrosis. And back to you, Sarah.
Thanks, John. So as you can see, ORKAMBI is a significant, has potential to be useful to many people with CF in Canada. And for that reason, CF Canada will be doing all that we can to ensure that people can have access so that they can potentially benefit from this new medicine. We hope you will have a look at the other segment of this WebEx that outlines the different things that you can do to help ensure people have access to this new medicine. Thanks very much for joining us.